Hello, everyone, and welcome to today's discussion. We'll be starting in just about 35 seconds as everyone settles in to the platform here today. Okay, so we're going to go ahead and get started. Welcome, everyone. I know some folks are still filing in. We have quite a packed crowd today, so we're going to go ahead and get started and respect your time. So good afternoon and welcome to today's discussion on health disparities and sleep. Next slide. I'm your moderator, Andrew Phillip. I'm the Senior Director for Clinical and Population Health here at the Primary Care Development Corporation based in New York. Next slide. So if this is your first time joining us in this series, Primary Care Development Corporation is a national nonprofit. We were really started in the 1990s, founded in a fundamental mission to address and enhance health equity and building the necessary foundations for healthy communities where it's needed most. We do this through investment, through advocacy, and through training and technical assistance across the country, including through today's discussion. Next slide, please. So we're pleased to partner with the SAMHSA Center of Excellence for Integrated Health Solutions in this initiative, but it's important that we note that the discussion today, our views that we're sharing are that of our own and not necessarily reflective of SAMHSA, of the Centers for Mental Health Services, or any other entity of the federal government. Next slide. So today is really the second part of our series here talking on sleep. And this is really part of a much larger national initiative where we're drawing attention to the integration of physical and behavioral health through taking a biopsychosocial approach to healthcare. We're doing this through improving awareness, but also training interventions that look for how can we use sleep in particular as a lever for improving health, but also as an opportunity for bringing together historically siloed perspectives of physical and behavioral health, as well as social and other forms of healthcare. Build our skills as clinicians, as leaders and decision makers in this space, but also develop a toolbox and a toolkit for how do we work together as integrated teams in clinics and in the world to really enact change and improvement in healthcare delivery. Next slide. So you'll see that this is a, as we move to the next, as this is a, again, part of our year-long series. We had a session that kicked off just last month on foundations of sleep. Again, today we'll be talking about health disparities in sleep. You'll be able to join us next month to talk about a specific lens from a behavioral health perspective for screening and intervention around sleep. We'll be sharing following discussions on folks with lived experience and family who are sharing experiences around what it's like to live with sleep-related conditions. We'll be talking about physical and medical interventions related to addressing sleep. And finally, we'll have a special session really dedicated to us as healthcare providers and our own experiences and needs around sleep. So you can actually access the registration for these and also past recordings at pcdc.org/sleep, where you'll also be able to find a recording and slides from today's discussion, as well as future discussions as they become available. Next slide, please. So we do have a poll for you, and we're really just trying to get a sense of who's all in the audience here. So our first question is, where do you work? Let us know if you work in a predominantly primary care setting, if you're more from a behavioral health perspective, if you're in that kind of shared integrated care area, and if you're not in one of those, let us know in the chat. And we see we've got a number of folks who are sharing out where you do work. And when you hit the chat box there and you hit reply, you can change it to all panelists and the audience so that other folks here in the audience can see you as well. But I see we've got folks dialing in case managers, refugee family case managers, folks from Head Start, all across the country, school-based psychologists, excellent, great clinical case managers, therapists, supervisors, excellent. Wow, we've got a lot of folks coming, crisis counselors. And there's a second part to this, and currently letting us know your actual function. Are you a physician? Are you a nurse practitioner, PA, therapist, social worker, care manager, others? And again, we're especially interested in knowing if you don't fall into these categories, where you're at. And so as folks are chiming into the chat, this is excellent to see. We'll pull up the results and share with you who else is in the audience. So you'll see that we've got a strong majority here who are from predominantly behavioral health settings, but excellent to see is also a strong representation of folks from integrated care, as well as, of course, primary care. And from a practitioner perspective, we see a lot of therapists here, but also a lot of folks in the other category, and that's so consistent with what we're seeing in the chat right now. I see PTs, I see outreach coordinators, provider relations manager, polysomnography technologist, excellent. So really good to see these things. So we'll go ahead and advance to our next slide. Keep them coming in the chat here so we can get a sense of who everyone is. So I'm going to introduce our panelists in just a moment here. And really, I just want to remind us of what we're talking about in the context for this. So as I mentioned, we're going to be talking about, continue our overall conversation on sleep, but we're talking about health disparities today. And I was chatting with our panelists just a few moments ago, and we are all really, I don't know if awe is the right moment, but we are in this incredible time. And to be talking about health disparities today, as we saw a storm on our nation's capital just hours ago yesterday, and we have been in a incredibly difficult but important conversation around race, around equity, and around justice in our country, all in the midst of a pandemic and in decades really of building health consequences that are directly tied to injustice and to differential even treatment within the healthcare system based on who we are or where we come from. These conversations are more important than they've ever been before, and we want to have them honestly, and we want to have a dialogue here today that is inclusive of different perspectives, but is honest and takes into account the incredible situation that we're in, where it's more important than ever to really call it like it is. And so that's what we're going to be doing today. And so I'm going to acknowledge that some of what we share today, it can be difficult, it can be triggering for some people, particularly for those who have already been either experiencing their own injustices around discrimination and disparities, or been struggling to talk about these things. Frankly, we're going to do it anyway because it's important to do, but again, we encourage you to do what you have to safeguard yourself and your energy, but hopefully this is really an aid for that. So I'm going to go ahead and introduce our panelists today, and in no particular order. Kim Prendergast is the Director of Social Determinants of Health at the Community Care Cooperative, which is a large ACO for FQ, or federally qualified health centers, based in Massachusetts, where she's been since June 2019. In this role, she really drives strategic initiatives addressing social determinants of health, building partnerships across the healthcare and social services sector that benefit many of the Commonwealth's most vulnerable. Kim brings public policy and systems orientation to this work while ensuring that patients' needs are met and really at the center of their efforts. She's been instrumental in designing and implementing the organization's flexible services program, working with community partners to provide support for C3 members experiencing food insecurity, housing instability, and homelessness that we'll hear more about today. And even before C3, Kim spent 2 decades addressing food insecurity and health with Feeding America, the nation's largest domestic hunger relief organization, with roles in public policy, nutrition programs, healthcare partnership, and consulting. And she continues to support this network of Massachusetts food banks to address food insecurity in the Commonwealth. She has also served as the executive director of the Metro West Free Medical Program. And also during this tenure, she led the organization's community partnerships, fundraising, and expansion of clinical services. Kim earned her Bachelor of Science in Dietetics and Nutrition, Fitness and Health from Purdue University, and a Master's in Public Policy from University of Chicago. Our next presenter, Dr. Tiffany Yip, is a professor and chair of psychology at Fordham University. She's a developmental psychologist, and she received her undergraduate degree in psychology at Cornell. She earned her PhD at NYU and completed a postdoctoral fellowship at the University of Michigan. Her research focuses on health disparities in sleep, discrimination, ethnic identity and adjustment among adolescents and young adults. And she has over 70 papers published in outlets including Sleep Health, Child Development, Developmental Psychology, Current Directions in Psychological Science, and others. And I think we'll hear about some of that today. She's also the associate editor for Developmental Psychology and a former associate editor for Child Development, Cultural Diversity, and Ethnic Minority Psychology, as well as the Asian American Journal of Psychology. She's an elected fellow of the American Psychological Association, the Association for Psychological Science, and was the inaugural recipient of the Early Career Achievement Award from the Asian Caucus of the Society for Research in Child Development. She's been a featured expert on Psychology Today, even recently, and her work has been highlighted on CNN, The Hill, the LA Times, and many others. And finally, Dr. Carmela Alcantara, she is an associate professor of social work at Columbia School of Social Work and faculty affiliate of the Columbia Population Research Center. She received her BA in psychology and sociology from Cornell, and with a concentration in Latino studies and a PhD in clinical psychology from University of Michigan. She completed her clinical internship at Bellevue Hospital here in New York, and also a postdoctoral fellowship as W.K. Kellogg Health Scholar at the Harvard T.C. Chen School of Public Health. Dr. Alcantara is a clinical psychologist with additional expertise in social epidemiology and behavioral medicine. She directs Sleep, Mind, and Health Research Program, the first at Columbia School of Social Work and one of the few funded programs on sleep and racial ethnic minority health in the country. In this program, Dr. Alcantara conducts research on social determinants of sleep that we'll hear about today, as well as mental health and cardiovascular health. A long-term goal of her research is to develop community-engaged and evidence-based behavioral interventions to promote health equity. So to that end, she also conducts interventional science research at the nexus of behavioral and sleep medicine, as well as mental health care equity. Again, we'll hear more from Dr. Alcantara, Dr. Yip, and Kim as we go through, but with that, I'm going to, we'll actually take down our slides here and have our presenters join us. And so we've got some discussion prepared for folks, and we're excited again to have an important conversation. And also, I'd like to really highlight that you, the folks here in the audience, are also the stars of the show. And so we want to hear throughout your perspectives, your questions, also your experience, and we're going to weave that into the discussion. Without much further ado, again, thank you to our panelists today. I abbreviated everyone's bios because you are incredible folks, and also, again, really champions in this space, and it's an honor to get to speak with you. To kick us off, I'm going to actually start, Dr. Alcantara, with you. We're talking about sleep, but also we're talking about health disparities. These are terms, particularly health disparities, I think that we are using a lot lately. Can you talk to us about what does this really mean? And from your work, is there really a difference when it comes to things like race and ethnicity and sleep health? And what does that actually look like?
Thank you, Andrew, for that introduction. And just want to say it's a pleasure to be with you all today, and the fantastic audience who I see they're very interactive and lively. So good to be with you all today. And also want to acknowledge how, that it's interesting that we're having this conversation at this moment in time following the events from yesterday. Because sometimes, when we talk about health disparities, often it's about how do you understand how structural level factors like race, ethnicity, where people work, where they live, where they play, how all of those factors affect their health. And at times it's really difficult for people to grasp how these larger macro level influences can really affect your health. And yet we take an event like what happened yesterday, which all of us bore witness to with what happened on the Capitol, and also, as you alluded to, the racial justice uprisings. And we can start to really see how these macro level factors, they may not be issues that are directly affecting you today, but how that then in turn can affect your own health because we embody those experiences. So that's a sort of roundabout way of saying that we're in this moment that where we can really capitalize to help people understand how these factors that are not just like individual choices that people make, but really the larger structural macro level factors that influence their health. And in many ways, that's what health disparities are about. You know, when we talk about in sleep in particular, there's been some debate about, are we focusing on sleep differences or are these sleep disparities, and how do you understand the difference? And you know, we think about health disparity related to reflect the difference, where the difference is adversely affecting a marginalized group, and that's what would indicate a health disparity. So a lot of, for us researchers, that would mean you're observing a higher incidence of a disease or a condition in one marginalized group compared to the other. And so that, versus if you're just examining differences between groups, but you're not comparing it to a marginalized group, that wouldn't be considered a health disparities. That it's important to consider that there's differential, both, I think, power and states, and that you're comparing a majority group to a minority group or a marginalized group, and that then you're seeing evidence of differences in the prevalence of the condition, in the burden, in the outcomes, in the impact of those health conditions as well. And then for sleep, you know, we know, and I know that this was covered in the first panel that you all did, that sleep disturbances, they're ubiquitous in the United States. You know, we know that 1 in 3 adults are you know, what we would refer to as sleepless in America. And what the research has shown, and this is based off several systematic reviews, is that racial, you know, that sleep disturbances are not distributed equally across racial ethnic groups. And so there's really well-established data to show that for Black adults, Latinx adults, or Asian, Native Hawaiian, and Pacific Islanders, that they are more likely to experience sleep disturbances like shorter sleep duration, so insufficient sleep, not getting the recommended amount of sleep, so 7 hours of sleep or less. They're you know, more likely to experience irregularities in their sleep timing, less deep sleep, so poorer sleep quality more generally, lower sleep continuity in comparison to non-Latinx whites. So this has been really well established. And even when we, you know, a common question that comes up is, well, what happens when you adjust for socioeconomic status? Are you really just seeing the effects of socioeconomic status? Because we know in this country that race and ethnicity and socioeconomic status are linked. But what we do see, in fact, is that these patterns persist, so that you see shorter sleep durations among higher socioeconomic status Black adults, for example, and compared to white. So it's not an effect that goes away once you adjust for socioeconomic status or once you start to parcel out those effects. So again, sleep disturbances are, they're ubiquitous. They're not evenly distributed across racial ethnic groups. We see that racial ethnic minorities carry a disproportionate burden, particularly for sleep duration and for sleep quality. That seems to be really, really consistent, and that there's these interesting patterns when you start to look at the combination of race and ethnicity and socioeconomic status and other marginalized identities as well.
And I just want to ask a quick follow-up question, and in some ways I want to establish a point that I think comes up a lot, especially when we're talking about healthcare. Would we say that these differences are not biological? They're not biologically driven? Yeah.
Yeah. So I thank you. You sort of, that was another major point to make, is that when we, and it's important to really be explicit about it, that when we're, you know, I just mentioned and gave examples of differences in sleep disturbances by race and ethnicity, but even though we've documented that there are differences by race and ethnicity, these do not reflect genetic differences. And so we know that race and ethnicity are social constructs, and what they're, you know, what they're reflecting is differential access to resources, right? And to risks, to exposures, to social environments that put people at risks of risk. So I just think it's so important to make that point really clear, that even though we know and that there's just well-established evidence that um, sleep disturbances um, differ by race and ethnicity, these are not reflecting genetic differences by races at all. And even, when we document race effects, oftentimes what are we really talking about or measuring? Is it about racism and structural racism and exposure to discrimination that's really at play in trying to understand these racial ethnic differences in sleep?
Thanks. Yeah, and I think that, I appreciate that, that clarity. I think because that, as we're having this conversation, and so for folks in the audience that know, we're going to highlight some of these. We're talking about disparity, but also one of our goals today is going to be, as we move through our conversation, what's modifiable and what can we do? And so that's and that will be a theme here. And we'll actually, and I should have just mentioned this earlier, we'll have a kind of a follow-on. We have some time scheduled at the bottom of the hour today. We'll have more discussion with the audience for almost an office hour here. So thank you, Dr. Alcantara. Really appreciate that kind of grounding. And I think that kind of takes us through to when we're talking about like, what are those differences and what are those drivers? And Kim, thinking about the health center environment, right? You have this, from your view, you have, I believe like quite a wide swath of individuals that are coming through your system. You have what's in their records, but also the stories that they're sharing from that kind of high level perspective. What are you seeing as the contributors? What's going on in folks' lives that are, that are contributing to some of these sleep disparities?
Absolutely. Thank you, Andrew. And it's so good to be here with all of you. So as Andrew mentioned at the beginning, I represent Community Care Cooperative, which is an ACO of federally qualified health centers in Massachusetts. And then I was also looking at some data sort of nationally from the National Association of Community Health Centers. And so community health centers are really seeing, we're grounded in the communities and working with all kinds of patients across the country. About 63% of the patients who are receiving their primary care from a community health center or a race or ethnic minority, about 37% are Latino, about 22% are Black or African American, and roughly 30% kids, 60% adults, and then 10% are seniors. And so I think at the starting point, we're really thoughtful about some of the health disparities that those individuals are experiencing, because we're thinking about quality measures and some of the kinds of physical health and behavioral health issues affecting our patients. We're seeing in those groups higher rates of blood pressure and worse blood pressure control, higher rates of diabetes and worse diabetes control, low birth weight babies, all kinds of challenges that the kids are having, less immunizations and challenges in schools and things. And so there's a lot of physical health disparities that also are associated with poor sleep. And then certainly, in the community health centers, we're doing lots of discussions with patients about their social situations and screening for health-related social needs, and starting to think about how those impact the work that we're doing in our clinical care. Across the country, many community health centers are using the Prepare tool, which asks about health-related social needs in a variety of domains. And there's 22 different questions. And I was looking at some data across the country. Patients face an average of 7.2 of those 22 risk factors. So on average, people are facing a third of the different topics that we're asking about, from food insecurity to housing instability, trouble with their utilities, unemployment. We dug in deeper with some of the data for members who are enrolled in one of our care management programs at Community Care Cooperative in Massachusetts. And this is just data since the start of the pandemic. And we're asking those questions a little bit differently. So looking really specifically at food insecurity questions. And for those of you who do some of the screening, we use those hunger vital sign questions. But 61% of the people who were asked these questions in Massachusetts during 2020, 61% were experiencing food insecurity. 16% were experiencing housing instability, and another 16% were experiencing homelessness at the time. So really staggering numbers we're seeing across the country. a dramatic shift in food insecurity as a result of the pandemic, and many states, and Massachusetts is actually the top of the list where food insecurity has increased because of economic instability and unemployment. And so I think as you're thinking about health-related social needs, the very top of the list for what's affecting people's needs is just economic insecurity. And we know that people who are low income are more likely to experience sleep disturbances, adults and kids. A lot of the work that I do is really focused on food insecurity. And I think what we see for individuals, households that are food insecure, and we really think about food insecurity at the household level, there are two aspects of food insecurity. One is the impact that food insecurity has on what people are actually eating, the quantity of what they're eating, the quality of what they're eating, which has an impact on their sleep. So poor quality diets, we know that people who live in food insecure households have eat less fruits and vegetables, eat less whole grains, eat higher, less expensive foods, which tend to be higher in carbs and higher in sugar, and which is associated with poor quality sleep. And so some research looks at food insecurity, people who are in food insecure households being twice as likely to have poor sleep. And then there's the stress of food insecurity. One of those two questions that's asked on that hunger vital signs screening question is, I worried that I would run out of food and not have money to buy more. And so even if people manage to put food on the table, it's at the expense of something else. It's at the expense of taking time away from something else to be able to pull it together. It's the expense of not paying for the car bill or the rent or something else. And so we know that stress is such a big piece of this. And I know that my colleagues will be able to talk a lot more in depth about the impact of stress on sleep. And then another social determinant of health that we're spending a lot of time on in our organization is housing instability and homelessness. And I'll talk more later about a program that we've implemented this year. But as we think about housing instability, again, the stress of worrying about not being able to pay the rent, or the impending eviction if someone's in rental arrears, and then housing quality, and so often people who are in a housing unstable situation, they're doubled up. It's a crowded situation. There are multiple people in beds or multiple people in bedrooms. Often the homes are potentially not as healthy as they should be. So there might be environmental issues that are causing respiratory challenges or pest control, or so all of the things that we tell people to do to get better sleep, like thinking about bedding and lighting and sound and quiet, and just isn't available to individuals experiencing housing instability or those kinds of situations. And then certainly for folks who are homeless, living in shelters, living in cars, living outdoors, adequate sleep is just really unattainable. So those are some of the key things that I'm thinking about from the health-related social needs standpoint.
Thanks, Carmen. Yeah, I think that illustration that you're giving, it's sort of, yes, it's stress, but all the things that contribute to that, whether it's sort of not knowing where the next meal may come from, but also, like you said, some of the environmental factors, that the crowding, it does, as a psychologist who has, treated a lot of people for insomnia and a lot of behavioral intervention here. That's the stuff that is often not in the manual or the textbook or the guide, right? Of like, telling someone to make sure that their room is dark and that it's cool and that it is quiet. Keep the cat out of your bedroom. This is not the conversation, that I was trained to have, certainly in my clinical training and in my work in this space, but it is what came up in life and in the clinic. So it's sort of, there is this disconnect. And Dr. Yip, I came across one of your articles that was recently featured by the APA, and that was part of what spurred this conversation. And so it was exciting to get to speak with you, and it was so timely. And so I'm wondering if you could talk to us a little bit more and share with the audience about in your work and your research, what have you been seeing lately? We started today by talking about kind of a little bit of the state of the world. How have disparities really been coming up, especially now in sleep, and how does it relate to what we've been talking about today?
Yeah, thank you, Andrew, and thanks to the panelists. It's great to be here with you today. As Dr. Alcantara started us with, the disparities are clear and they're pretty well established. And so what we've really been interested in is trying to unpack what are some of the mechanisms that link to disparities in sleep, with the ultimate goal of sort of disrupting some of those links. And so some of our research has focused specifically on adolescents and young adults in New York City, looking at stressors like discrimination stress. And so the article that you're referring to, Andrew, we did a 14-day sleep diary with, having kids wear actigraphs, which are, fancy medical grade Fitbits, tracking sleep and really trying to pin the day-to-day impact of discrimination on sleep. And what we found was that on days in which adolescents experienced discrimination, they also experienced same day disturbances in sleep. So you really start to see the one-to-one correspondence between an incident of discrimination and same day impact on sleep. And interestingly, those effects don't sort of dissipate until a couple of days after an isolated discrimination incident. And so, that got us sort of thinking as developmental psychologists, when you are in environments or, neighborhoods where discrimination is not isolated, it's not a one-off thing, these repeated exposures to discrimination, you can imagine how that over time can sort of lead to a pathway of disparities. And, I think the other interesting thing to think about here is that folks who do research on discrimination stress, we know that you don't actually need to be the target specifically of discrimination, that there are pathways that we call vicarious pathways, which, it can happen to people of your racial ethnic group. It can happen to fellow citizens, as we saw yesterday, even though many of us were not, directly affected or, at the Capitol yesterday. I would venture to say that many of us, myself included, were impacted last night in terms of our sleep. So, discrimination, I think we should use broadly as a term to think about, ways in which people are treated unfairly, differently, in inequitable ways. So there's lots of layers to discrimination and lots of layers to discrimination stress. And in our research, at least, we find that is that impacts sleep.
Yeah, I mean that's interesting as far as the specificity in what you're describing. That it's not just that we see there's an impact on when someone experiences discrimination and sleep, but it's actually we can measure it and it extends beyond sort of just that day. And what you said about the sort of cumulative impacts, I've got to I can't help but wonder if like in this in this moment, in this year, in these past few years. As much as we're talking about these things and trying to unpack them, but also seeing them, like you said, on the media, and as we're sort of glued to the TV, how that's sort of amplifying things, especially like you said, for adolescents, and I also imagine for others. It's got to be sort of multiplying, I imagine, lately.
Yes, and I think it will take a couple of years for us to fully appreciate and unpack the impact of, the multiple stressors that we faced in the past several months. So, there's certainly the pandemic, and we have some research that looked at sleep in the pandemic, but, also this sort of racial reckoning that we've had in the past several months with the BLM movement. I mean, these are not, again, isolated incidents. There's a pattern, and I think it's going to take us a while to fully unpack the impact of that on sleep and health disparities in general.
Dr. Alcántara, I know that in your own research, there's I imagine there's some parallels here. Have you been seeing changes and shifts as well? Are things looking different these last few years than they were before?
That's a good question. And I think to echo some of what Dr. Yip said, I think it will take us some time, to figure out and really unpack the the effects and tease apart, the impact of this, of these various stressors, including community stressors on sleep. With the work that I've done with Latinx immigrants, what we've also found in the Latinx population in general is the independent effect of acculturation stress, which is, stress related to the process of adapting and integrating to the US mainland culture. And what we find is that this specific kind of stress has an independent effect on insomnia in particular, which is one kind of sleep disturbance. And in one study that we did, we looked at the combined effect of both discrimination, acculturation stress, and just a chronic stress burden. So sort of the amount of stressors, like a stress count of chronic stressors, and found again that this acculturation stress seemed to be particularly salient and an important correlate or factor for insomnia in the Latinx population. So I think it's interesting because in this acculturation stress variable, there's elements of it, or there's some questions that assess for experiences of interpersonal discrimination, but it's really rooted back to their identity as either their migration status or their language or their cultural heritage. And so I think we have exposure to racial ethnic discrimination, and then you can start layering, right, the effects of racial ethnic discrimination within other social identities that people carry, like their, it could be their migration status or their cultural status as Latinx adults. So I think sort of related to, I think, Dr. Yip's point about we do know that exposure to discrimination is adversely associated with sleep. And I think, the work that her team has done in terms of unpacking those even potentially bi-directional relationships is really important. And then thinking about, well, how do we try to understand the other kinds of stressors that are related to people's social identities and how that might also impact sleep is also important.
Great, I appreciate that. So yeah, there are these, I think, like you said, there's things to unpack, and also, we're sort of in this moment of, okay, so what do we do? And this is really, a question to everyone, including our audience. But when we think of kind of who's here today, we have folks who are healthcare providers themselves, but also other sort of key players in healthcare system, also in government and other stakeholders. We've got a great set of folks who are joining us. Whose responsibility is it to do something about this? Who needs to be the actor here? I think we can, based even from the conversation so far, obviously there's sort of deep social constructs that are at play here too, but who should do what is my question.
Well, I won't propose to know who should do everything, but I think as I think about what can we do as opposed to who must, at the community health center perspective, there's I think starting by identifying some of the issues that people are having that impact their sleep, their health, and importantly thinking about what it is that we can do to provide some meaningful solutions. We know that we've been asking these health-related social need questions for a really long time. But this year, we had the opportunity in Massachusetts to launch a flexible services program that allows us to use Medicaid dollars to partner with some nonprofit organizations across the state to implement food insecurity and housing stability interventions. So we were able to launch a program to provide grocery store gift cards and home delivered meals and home delivered groceries and a variety of other services for nutrition needs, as well as working with several housing partners across the state to help our members navigate the housing system in Massachusetts, to access financial supports, to find apartments that might be appropriate for them, and to pay for a lot of home modification needs. So if people needed pillowcases and mattress covers and bedding, and they needed air conditioners or air purifiers. I mean, air conditioners in the summertime when people are living in a really hot apartment, I mean, that's a really simple solution to be able to help someone control the temperature in their environment and then sleep better. So we were able to serve, thousands of people this year with some of these really small, in the grand scheme of things, several hundred to a few $1,000s worth of interventions, but improve their food security status, improve their housing stability, make their environment healthier and a little bit more comfortable, or even in many cases, help people move into a new apartment, or if they were homeless. And one of the things that we found, in addition to, we're starting to see some trends towards it's actually helping to make a difference for health outcomes, but more, another big impact of that is the ability to refer our patients to an intervention that's helping them allows the health center staff who are asking these questions to, first of all, be better able to ask a battery of screening questions. So they're not as timid about asking one more person about their food security status or one more person about their terrible housing situation because there's nothing that they can do, but instead saying, okay, here's a plan of action. Does that work for you? And we're hearing across the board that helps our clinical staff better set up the relationship, develop some trust with patients to then dive into other conversations, which might be, and how are you sleeping? My goodness, that's a lot that you're dealing with right now. Or it might be, let's figure out how to manage your diabetes so that you're in better control, and maybe that will help a variety of things like how you're sleeping, or et cetera. So I think starting to address some of these little pieces that make up a lot of what is, the drivers of health disparities will ultimately start to make a difference.
Yeah, and I appreciate what you said about, coming up, like making sure that the questions are there that are in place even to find out about these things. And I'm thinking about, a lot of the folks who are, who are in our audience today, and all those different roles that we saw coming through. Dr. Yip, thinking about some of, the work that you've done, talking about discrimination in adolescence experience in particular. Any suggestions of, again, this question was not in my manual. How do we have those conversations, and how do I kind of, whether I am, I'm a psychologist, or whether I'm working in a, doing, interventional work around addressing, pulmonary concerns. We have folks who work in sleep clinics. How would you say to have these conversations? Are there specific questions to ask? Is there kind of a context to set up?
Yeah, I think that's a really important question. And I think there's actually lots of layers to that. I think, just simply asking people, if they come in with a physical health symptom, how have you been sleeping lately, right? And even if you just ask that, even outside of, a clinical setting, if you're talking to friends or, family members, people are often not shy to tell you how they're sleeping. It's a pretty popular topic, like, oh, I couldn't sleep last night, or, I think it's a pretty safe topic to sort of address, and people are quite open about it. There are, sort of contextual level interventions that people have done, sort of reestablishing what the social norms around interactions are. So school-based interactions, really sort of targeting bullying and exclusion that have had, measurable impact on, among adolescents, the types of interactions that they have with each other. So I think to really move the needle at a population health level, I think it's important for us to consider those context level interventions. They get us sort of, I think those individual conversations and talking about, sleep hygiene and, temperature in your room and darkness and all that, I think those are great. But I think really to move the needle at a population level, we need to think about contextual interventions. And we also need to combat this sort of narrative we have in this country about the value of sleep, right? So how many times have we heard, sleep is a waste of time, I'm much more productive, I only need 5 hours, so that sort of narrative, I think, needs to be counterbalanced with, hey, these are the reasons why it's really important to sleep. And instead of, spending another hour, on social media or, watching TV, this is what it could mean for you to sleep an extra hour tonight. So I think those sorts of things, just sort of underscoring the importance of sleep. And then I think more structurally, we have to take a really close look at what we value as a nation. So we know that things like shift work make a difference. In the context of COVID, we know that people who are essential workers had their sleep compromised. So we collected some data on that among young adults. And so, as a nation, I think we need to ask ourselves, like, who are the people who are disproportionately represented in shift work? Who are the people that are disproportionately represented in, neighborhoods where crime is higher or neighborhood safety is an issue or noise levels, all these things that we know impact sleep. So I think those are sort of the tougher questions we need to ask ourselves, but I also think those are the ones that are going to get us a little bit closer to sort of narrowing some of the disparity gaps.
And Andrew, I think if I could jump in, I guess I had just two thoughts while my colleagues were talking. One, just wanting to underscore what Kim said about, I mean, you didn't say it this way, Kim, but I felt like I'm interpreting that way, that there could be unintended consequences to screening for these social determinants without having resources for people to go. And so I think one of the beauties of what you described, Kim, is a system where, the practitioners, it sounds like on different levels, are able to screen for these factors, and then they can plug them into resources. And so I think if those don't yet exist in whatever community settings or frameworks people are working in, I think thinking about structural ways of capacity building, whether it's at the neighborhood level, at the community level, to be able to meet those needs. Because I think collecting the data, I mean, that's a good thing, but really it's more important to be able to link people to resources to be able to address some of these social determinants. Otherwise, it can be harmful. And I think the other point is, these disparities in sleep, we don't only sort of see them for racial ethnic minorities from lower socioeconomic backgrounds, we also see them for those with higher socioeconomic backgrounds as well, as is the case for, there's really good data to show that among, Black adults who are in professional occupations, their sleep or they're more likely to experience shorter sleep durations compared to their same, white counterparts. And Black counterparts in other kinds of occupations. And so again, what do those structural solutions look like when you're thinking in a whole, across the socioeconomic status spectrum? I think is just, an important point to consider.
And Andrew, I'll just say, thinking sort of structurally, what can we do? The opportunity to think a little bit differently about how it is that we pay for healthcare. We spend a lot of time thinking about, what would a primary care capitation model look like as opposed to fee for service? If we weren't asking the doctors to ask one more question during their very short window, but instead thinking about how we can holistically take care of our patients, and recognize that for some subset of the population, let's really ask everybody this question, and be certain that we have, from a sleep perspective, maybe it's not an intervention where we refer them to a nonprofit partner, but it's having somebody on staff who can have that conversation with them, who in the model that we have right now probably wouldn't be a reimbursable visit, but under a different kind of payment structure could be. And so I think that's a really important conversation that we're having, thinking about how is it we can pay for our work differently so that we can really value some of these important aspects for people for whom it can make a real difference to their health and their well-being.
Yeah, I think there's a big kind of underscored message here, and part of that, and as we've been talking now for years about integrating different services and getting the right people in the room to get our patients the care that they need as whole people. There is a whole parallel discussion around how do we pay for that and how do we do it the right way, and not solely rely on things like a short-term grant or something like that, which have been kind of great startups, but only take us so far. There is one thing I want to come back to, Dr. Alcantara, I think you alluded to this, and Kim, you were talking about PEARLS and some of the assessment tools that you use for looking at social needs. And at the corner of my eye here, I saw some folks in the chat also talking about like the safety of systems here. How have you, like in your health centers and those that you've worked with, and decades of work you've done around needs like food insecurity, how do you create a space or like an actual setup where you can safely ask about these things? Like when you as you've instituted social needs screening, for example, and kind of bring that into the discussion, how do we create like an ecosystem where it feels comfortable for folks to respond to those things and answer those questions?
Sure, yeah, I'll start, and then maybe my colleagues have other things to add too. So I've been, encouraging and advocating for food insecurity screening for a long time, and then I've really, we've expanded as we're thinking about, multiple aspects of health-related social needs that we want to ask about. And I think one of the things that we see that makes the most sense is when it's being asked in as normalized a way as possible. So when it's being asked in person, I ask all of my patients this question, really make it seem like I'm not signaling you out, singling you out because of your race, because of your ethnicity, because I think you're somebody who is in a low-income household, but making that seem as common and as routine in the visit as possible, and certainly asking those questions on a regular basis, because we know that research shows that oftentimes people aren't willing to disclose some of that information, that I'm experiencing food insecurity, or I'm worried about losing my housing the first time they're asked. But once they start to feel like this is something that I'm asked in a safe space, maybe I really will be able to get some support. We've seen in research that individuals say oftentimes they're not willing to disclose that if they don't really think that there's something that they'll get in return. If there's not an intervention, if there's not a solution, why would I tell my doctor that I'm worried about putting food on the table because my kids might be at risk, or what might this do in the long run? So I think the other thing that we see is really different considerations in different settings about how those questions are asked. Are they asked in person? Are they asked by a medical assistant who might be of the community or similar cultures to the patients more than the physician, and feel like it's not an imbalance of power when the question is asked, so it's easier to have the conversation? Are the questions asked on a tablet or on a piece of paper as opposed to in person? Because in some settings, there's research that shows that they get higher rates of responses as a result. So, unfortunately, there's not a one-size-fits-all answer to that, but certainly the culture matters. And I will say, I think right now is a great time to start asking those questions if it's something that folks have been thinking about and haven't been doing, or maybe put aside because of COVID. We're hearing from our health centers that the rates of food insecurity, rates of housing instability are, both much higher, but they also feel like some of the stigma is gone because we're seeing food pantry lines in the national news. We're hearing about the crisis of potential evictions right now. So suddenly, recognizing that others are experiencing these same issues makes it feel like a safe conversation to have. Or maybe people are just struggling more and sort of at their wits' ends and willing to talk about it. But certainly it's a good time to talk about it because there's a lot more awareness, for sure. And I see there's a question in the chat. I'm going to take a look at it, and maybe somebody else has a question, wants to elaborate.
Yeah, I think I would just want to, I think that was a really terrific answer, Kim. I would just add, I think it's helpful to also, in addition to implementing a strategy where everyone, every sort of patient client is being asked about these social determinants. The example Kim gave was food insecurity. Assessing for strengths is also really important, so that it's, you're getting a sense for strengths of this individual client, community, patient, family support. So I think in creating that culture of we want a holistic evaluation of you as a person and within a family system and community system, attuning to strengths is really important as well.
Yeah, definitely. I think that, both those points, and I think, where we just landed there on a really strengths-based assessment that takes into account culture and like family and sort of like, I in other conversations, this has come up as well, sort of phrasing things as, when you're growing up, how did your family, how did the people in your neighborhood who you kind of live around, how did they talk about sleep? How did they talk about stress? What did you see there? And to that point about sort of like now being this interesting moment, in every certainly, I'm curious if your experiences have matched this, but in the patient, in the clinical care that I do provide, everything that's coming up in the world is coming up there, right? And so sort of there's this like tendency to, I think, for everyone just to be like, oh yeah, it's all a mess and those things, but I find it makes a difference what those follow-up questions are, and sometimes it's uncomfortable, but asking about thinking of certain individuals I've worked with, what is it like being a Black man who's walking down the street when this is happening? Has this changed anything in your community? Is this something that you've been talking about? And calling things out that are in the room, and I'll acknowledge my presence and sort of my, different background and lack of understanding, and sort of invite in like a real, bringing a real cultural humility to it, and sort of acknowledging my own limitations, but trying to make those conversations, like to what you've all said, sort of normal, and calling them out, and using the current events that are happening now to acknowledge how unsafe things can feel, but also how on the table so much is. And it's, I think particularly with sleep, as you've all mentioned, sleep can sort of be like this, who's ever sleeping, oh yeah, my sleep stinks. But I find many folks that I've worked with in the past are very eager to talk about the news and talk about current events. It's what we talk about in the hallway when we're walking down to the clinic office. And then if we can, connecting that with sleep, so like saying, gosh, that protest that you walked by, or, what you've been seeing in the news, what a mess. Yes, but how's that been? Have you noticed any changes in your sleep? And sort of connecting those things, and even thinking about the pearls. And I imagine as you go through those questions, okay, so we know that you have needs around housing, that you have needs around food, and or even when someone acknowledges that they're working, double, triple shifts, to keep the lights on. I think as sort of mental health folks, we tend to kind of default to that's the emotional support that people need, and acknowledging how tough that is. But I think specifically tying to something like sleep is not always the leap that we're making, and there could be opportunities there. I don't know if that kind of matches your experiences, or if you have anything better advice than that.
I'll just share a little anecdote here. We just finished a grant that we were doing with the Boston Public Health Commission, which is the largest public health commission in the country, and the Housing Authority, and a medical legal partnership organization. So it was a really multidisciplinary group coming together to work on housing instability in low-income pregnant moms. And so the advocates from the Boston Public Health Commission had the ability, we had some funding to be able to provide for some specific needs that the members had, without a ton of restrictions, all within sort of the goal of improving housing stability. And the most common request that we were getting was for new mattresses for the moms or cribs for the babies. So I think that they, those advocates working with those moms and really talking about, thinking about, if we had a little bit of money to make something better in your life, what would it be? It was, let's make sure that you have some of these very fundamental, items in your house to be able to get some sleep and take care of yourself.
And we're actually transitioning now, so we're kind of reaching the end of our kind of initial hour here. And I know some folks in the audience will have to kind of hop off. People are asking about the recording if they've joined late. We've had people who have been dealing with crises and other things. Yes, recording will be available at pcdc.org/sleep. But I'd invite folks now to, we're going to kind of, there's been a lot of activity in our chat and folks kind of sharing their experiences and questions. Panelists, if you're all gracious enough to stick around for a little bit, I'd like to talk through some of these. And hear more from our audience specifically, who's really been active here. And my colleague, Kristen Potterbush, has also been facilitating here. And Kristen, I don't know if there's anything specific that you want to mention, and we'll also talk about what we've been seeing here.
Thanks, Andrew. I think a lot of the conversation in the chat is, number one, recognizing how important this information and the content is that our presenters are speaking about today. And I think that folks are really interested in hearing, specific examples and ways that some of this can be further distilled down into their practice and sort of their day-to-day interactions with patients. And so, we're getting questions around screening for persons, who are struggling with nightmares. We're getting questions around specifically working with individuals who are Caribbean. And so, I'm wondering if the panelists could maybe kick off this office hour by, sharing maybe one or two examples or maybe short case studies that are just really specific, and take a deeper dive into something that you think, might be relevant for some of our audience today.
I shared a little bit about this actually in a last session, but it was on my mind actually as we were just talking. So I'm gonna jump in myself and share a little bit about, a case that I've highlighted briefly before, but I think is sort of really speaks to this. And so, this is from years ago, but as a psychologist embedded in primary care, I'd often get referrals that were for folks who were, non-compliant or sort of not following medical orders for their own care. And and in many cases, it was folks who had obstructive sleep apnea, a condition where their sort of airway temporarily closes or is obstructed during sleep many times over the course of the night. And we know that sleep apnea, for example, there's also significant disparities around. This individual was, they're African American, and they were also dealing with housing instability and inconsistent access to employment. And so they were sent to me by pulmonology, presumably because they could not just get with the program as far as using their CPAP, the mask that they have to wear for the equipment that is designed to treat their obstructive sleep apnea. Usually there's some sort of data monitoring component where you can measure someone's use of the CPAP machine, the amount of air that's flowing through, how consistently they're using it over the course of the night. And the sleep docs were noticing that it was inconsistent. And they talked to the patient about it, and it was sort of unclear what the problem was. And so it was sort of deemed that perhaps it's got to be behavioral. And so send them to Dr. Phillip and help sort of get them doing this thing. And this was, this was at a point in time where doing things like pearl screening and screening for social needs wasn't, and I know it's still often not quite the norm, but in talking to this individual, their biggest stress was that they haven't had a place to sleep, and that they've been sleeping in a car with other members of their family. And that came up, but it started with the conversation around the CPAP. It was like, sort of like, what's going on with this? How's your sleep? And we did a full sleep assessment. And in my full sleep assessment, there was no sort of question about like, your access to outlets or plugs. But again, that came up of having like, yeah, I've got this CPAP. I don't exactly understand what it's for, but I don't know, I can't plug it in. I don't have an outlet for it. That sort of addressing that need was like the lowest thing on their list. And yet when we looked through the medical record, it was like the glaring sort of compliance issue. And so that really that kind of, for me, really symbolized and embodied a lot of the conversations I'd have. And it was often, right, my neighborhood is unsafe. You know, I do have many people who I'm living with. I may not have access to housing. I would come up very practically like that, but it isn't necessarily part of the assessments that we often do. And especially thinking about when someone's referred to pulmonology or another specialty service, it's not what's coming up. And it's something that they're also, again, like not necessarily comfortable talking about. So that's just one example of it, but, you know, curious if, you know, if there's other ways where we see this manifesting where it may not necessarily be immediately obvious.
Andrew, this is slightly different, but I think related. So I'll share this story and can keep thinking about sort of cases that may be, or case studies that may be more relevant. But in some of the community sort of health education work that I do in the Spanish-speaking Latinx community in New York City, what I have found is that in trying to talk about just sleep health more broadly and, you know, promoting sleep health, sometimes when I would talk to folks, you know, and here, you know, these might be folks who are commuting long distances, they have multiple jobs, you know, they might be dealing with issues of food insecurity. So really more on the lower socioeconomic status end, where I would find like I'm trying, you know, I'm giving my best pitch for the importance of sleep and just, you know, trying to sort of do some psychoeducation around it, and have found that the most traction that I get is really when I try to frame it within like a family context and really thinking about the intergenerational effect of, you know, and I'm specifically thinking about some of the women who I talk to, some of the moms who I talk to who, you know, I like, we would, at some of these community health events, we'll do some insomnia screenings, and there would be interest, but then when we would try to talk about, well, what are some of the potential options for you, that it would, you know, there would be some reluctance to engaging it or thinking about, well, how, you know, I don't have the time to really dedicate to improve my insomnia. But when we talked about, and I've had instances where, you know, I'm talking to a mom and her like 10-year-old is right next to her, you know, and we start talking about, well, you know, do you actually know that the way you sleep could actually affect the way your child sleeps? And then I've had, you know, a case where then the mom starts telling me about, actually, she does have trouble sleeping. And I've been talking to her pediatrician and I'm not, you know, we're trying to figure out the best thing to do. And I've been to this, you know, had a referral for this pediatric provider to get more details, but something about this intergenerational, I think, narrative and familial narrative, particularly I'm talking about a Latinx women, that was so important. So I think like framing sleep as not just an individual issue, you know, as not just an individual problem to be solved, but the importance of sleep for family health, I think is really important. And there's a lot of potential, I think, traction from a clinical perspective of presenting sleep and poor sleep as a family issue.
Yeah, I think that talking about the family piece, I mean, that, you know, even, you know, Dr. Yip thinking about, you know, again, like working with adolescents where there are sort of, you know, you sort of have like control over your life at that age, but also in so many ways you don't. And, you know, in my own work, you know, when I've worked with adolescents, I found it to be like incredibly challenging because of, you know, I always wanted to kind of like bring the parents in and be like, look, you know, can I sort of change you or their schools or others like those? And I think that's probably the frustration of being young as well. But any advice kind of thinking about young people who are you know, who are experiencing those disparities or who the system itself may sort of amplify disparities for, because I do think there's differences there.
Yeah, and I, you know, I think that's a really good point. And I also noticed in the chat, someone brought up this issue of school start times, right? Which is a really hot topic about sleep and particularly high school students. And there's a lot of national debate. California passed legislation earlier this year that moves start times for the entire state. You know, they have a couple of years to sort of roll that out. But, you know, these are sort of meaningful differences that we can think about for adolescents in particular. You know, and how we can support kids, because we know their biology doesn't map on to this, you know, sort of somewhat arbitrary school schedule that we're imposing on them. So, if we can sort of reimagine what those schedules should look like, and, could we consider mapping them onto, circadian rhythms of kids at that age, how much more would we be supporting the health and academic outcomes of kids? And again, is this a potential lever for mitigating disparities that we see? It's an empirical question, but is it possible that school start times have a differential impact, in fact, right? So we know sort of across the board that later start times that match circadian patterns are better for kids. But is it possible that that impact is not the same across the board, right? And so that's, I think, a really interesting question for us to interrogate a little bit more. But also listening as you guys to you guys discuss sort of the social and underpinnings of sleep. So you sort of started the session talking about this biopsychosocial framework. And so if we sort of really take those pieces together, I think it's often sort of the social aspect of sleep is often underestimated. So there's some work looking at college students in dorms and this notion of social jet lag, right? So that, again, sleeping off your clock by staying up late and hanging out with your friends in the dorms, that can have an impact on your system very similar to traveling to a different time zone. So I think thinking about those social levers and maybe how we can sort of thinking about addressing those can be an important, maybe, getting our foot in the door to thinking about ways to have a larger scale impact as well.
The family impact and sort of like some of these unique dynamics is also I've noticed is also resonating with folks in the audience here as well. Also thinking about things like co-sleeping and really the and I do think there's cultural variation here on this too, of like the importance of sort of going to bed with somebody, sort of whether you're tired or not. Again, like what does it mean to sort of sleep together in your family, for you, in your culture, in your society, in your personal values, right? Like those things, it makes it, it changes the story, right? There was someone, actually, an interesting, one of the recent comments I'm going to just read out here that came from our polysomnographic technologist who scores sleep studies as well as fits patients. So we were talking about sleep apnea earlier and sets them up with their CPAP or their sleep apnea treatment, follows them through therapy and compliance. They acknowledge this kind of behavioral versus contextual factor, and noted that from their experience, although it's true that compliance is a problem with CPAP usage, although I believe that we have to understand that there's also this huge life adjustment of just using it, right? They did have patients open up to them about the situational aspects that directly affected their CPAP usage. It's important to help these patients through these external problems and offer them resources that can directly impact CPAP usage. And I really appreciate that they highlighted here. It's talking about sleep not only at the individual level, but how family impacts sleep as well is also true for CPAP usage. And so I think that's so, and that's so important because we do have a lot of folks who come from some like the specialty areas and pieces that touch sort of that primary care behavioral health sort of central point. And so it's really exciting to hear that perspective as well. But yeah, when we think about things, sleep apnea, and we're going to talk about sleep apnea later this year when we have a session on physical and medical interventions around sleep. But that's another one where, again, sort of concerns around like who else is in the room with me when I'm sleeping. Is there a place, am I sort of burdening others? Again, if we think of families where one member of the family may be waking up to start work and the other one is just coming back to go to bed. Concerns like that can come up where they don't want to interrupt the other person sleeping. Your point around Tiffany around school start times, right? Again, I think of children that we've worked with in the past where just as they're getting home from school, they're also having to then care for other members of their family or their parents, or there's a whole sort of job that children are doing before they get to school, sometimes seeing off their siblings and others to school, when there isn't another sort of parent or guardian or other person doing that work, that changes it too. And so there's these unique components that I think are sort of embedded in some of these disparities and differences that sort of change how we can, what our focus needs to be in these discussions.
Yeah, and I think it's just really important to underscore that all of those issues disproportionately affect,
Yes.
those who can't pay for childcare, those who can't do the after-school program, the before-school program. So it is up to different members of the family. Even though they're tired, they still have to get up early, stay up late, because that's just the only option for that family, and so it certainly impacts sleep in many, the stress and many of the other aspects of health and well-being.
Yeah. Kristen, other things that have come up in some of the discussion we've had, there's a lot of dialogue happening.
Yeah, absolutely. And thank you everyone who's submitting. We are getting a lot of questions in just to us panelists. So feel free if you have a question or want to start a conversation with the other 235 odd participants to not just share with us, but you're of course always welcome to share directly with us if that's more comfortable for you. We have gotten a couple questions around individuals who are on the call today who work with folks who are living in situations of scarcity, individuals who are in poverty in urban and rural areas. And we've got some providers on the call who are wondering around specific insights that our experts here might have for supporting individuals in those scenarios who are living with sleep issues. And I know we touched on that a little bit earlier. Andrew, your case study there around CPAP machine and of course there can't be compliance if there's no option to plug the CPAP machine in. But I'm curious if anyone else can speak more to maybe direct suggestions for some of our providers on the call today when serving individuals who are in positions of extreme scarcity.
Kristen, is the question more specifically around sort of tapped into the CPAP question, or just generally about individuals who are living in extreme poverty?
Right. So, and this is what I get for trying to combine like 4 questions into a single question here. No, it's less about specifically the CPAP and more around any specific suggestions that y'all might have for providers who are serving patients who are in positions of extreme scarcity and also struggling with sleep issues, and sort of what can providers do in those situations. Are there suggestions that you would have?
Right, my colleagues are going to have all kinds of better sleep specific recommendations than this, but I'm just going to start with a really a basic one. But when people are in living in poverty, wearing my food insecurity hat, the very first thing that comes to mind for me is making sure that people are referred to enrolled in the SNAP program, so the Supplemental Nutrition Assistance Program. So is one of our country's best safety nets for food access, and so improving food security, so both making sure that they have better access to healthy food, and that we start to alleviate a little bit of the stress of food security is something that if that's not on your radar, should be, to make sure that somebody on your team is thinking about if folks are connected to that, and then any other local benefits that make sense for them in terms of making sure that they're getting the right kind of health insurance, and if there are other housing subsidies and utility protections. Right now, certainly that's a really important one. In many parts of the country, there are utility shutoff protection kinds of subsidies, as well as opportunities that you can all do to be sure that people's heat doesn't get shut off, particularly if they have a medical condition or they have a young child or a senior in the household. So there's some pretty standard, non-sleep related, but can have a big impact on stress and on the sleep in the long term.
Kim, I would say those are all sleep related. Those are, and I think your point or your suggestions really just make me reflect. Like these are complex issues. They're going to need multi-level kinds of interventions. So thinking about, it's not going to be one behavioral intervention, but really, I think among all the interventions that Kim mentioned, and then also I think trying to, from a strengths-based perspective, also trying to get a sense of that, of the home environment really, and sort of, are there places to begin to implement small or proactive changes in their sleep home environment, while at the same time, I think getting and connecting folks with resources that could really be helpful. But I think I think the main point I just want to make is that what several of you have highlighted are really related to complex problems, and just thinking about this as a problem that that requires multiple kinds of interventions at multiple levels is really important.
Yeah, I think there's almost, I think for some of us, there's almost like this paralyzing nature when we're sort of confronted ourselves, in healthcare with problems that seem, from our perspective, insurmountable, right? Like, what do I do when, so you don't have anywhere to sleep, you don't have enough food to eat, like, how am I, like, if I can't refer you, what can I do? And that's certainly an experience I've had working with many folks who are in poverty or experiencing housing instability. And and I'll speak to that in a second, but there's a question that I was just reading through, and as we're talking in the chat here, or an experience being shared. One of our audience members created a program, an evidence-based intervention that's been in shape, that's been used across really urban and rural areas of the country, but largely for people with serious mental illness. It includes emphases on physical activity, healthy eating, social inclusion, engagement. But most of the participants, they note, are poor. They cope with all sorts of these social terms that we talked about, and of course have the lower life expectancy that we've seen there, with sleep being a major issue. And specifically, it says here, their life circumstances and quality of life clearly impact upon them. Their multiple medications create issues as well. Any thoughts there, particularly around this population? And they highlight the medication piece. And I'll share. One of the things that, and I think this again comes back to this idea of like when from the healthcare provider ends, when it feels like our patients are being confronted with these insurmountable odds, it feels almost like what can we possibly do? But even at that level, and especially with folks who, one of their sort of like social circumstances is so tied to their mental health, we often see that either people, and again, we'll have actually an upcoming session this year specifically on assessment and intervention related to medication and medical needs. So we'll talk about this more, but we often see that, and I've certainly seen in clinical practice that folks who are, certainly we know that specifically people of color, people who may have lower health literacy, people who are not native English speakers, for example, particularly in systems where there's not other representative folks working, and people from generally disadvantaged backgrounds tend to, one, we know that they get sort of like, in general, worser care, right? Their screening they're less likely to be screened for appropriate conditions, and then the actual intervention tends to be different. But one thing that I see frequently is that there are also many folks who don't sort of like speak healthcare lingo, or often have barriers to service, are actually over medicated, or don't necessarily understand all the medications that they're taking and why. I think we've all, those of us who've kind of worked in medical settings, we're familiar with the patient comes in with a sort of like a shopping bag full of pills, right? And some of them are expired, and I don't know why I'm taking these things. And so sometimes it's, although I can't solve your experience of housing instability, I can help you with some medication reconciliation, kind of going through and understanding, sometimes there's even components where, a medication that should be taken, at HS, and it's like, what does that mean? Well, actually, that's not supposed to be taken first thing in the morning with breakfast. That's hours of sleep. Like, it's helping folks be the driver of their care, and really being an advocate for our patients is often, that can be a starting point around impacting the effects of sleep, right? So helping make sure that our patients really understand and are actually behind the medications that they're being prescribed, that they are empowered to have open conversations or disagreements with their healthcare provider. You know, if they don't understand why they have a CPAP, or if that was just sort of given to them by somebody that they've never met before, there's not continuity on their care team, that could be enough. Like, there's all these other obstacles that are actually existing in our delivery of care. And I think that is another place that, especially when we're talking about disparities, looking sort of inwards at ourselves, and our systems, you know, are we doing enough to make sure that people, you know, even if we can't control what's going on outside of the system completely, are getting the maximum benefit from our actual delivery of services? You know, are we providing materials in languages that people understand and relate to? You know, at a very basic level, are the people that are working in my health center or in my clinic, they look like and they talk like the patients who live in that area, right? Kind of talk about creating trust, like all those things that we would do in general, are even more so applicable here when we're talking about disparities and talking about sleep. I'm not sure if anyone else wants to comment on that. I can expound on this for a long time.
Andrew, the two things that came to mind when you were saying that, one, I can't believe we've gone an hour and a half with being an ACO health center person without saying the word telehealth. But you know, during this phase, one of the things that we keep hearing is that from a telehealth perspective, medication reconciliation takes on a different meaning when you have, you know, and there are certainly disparities in access to technology and things, but for individuals who are taking so many medications, the ability to say, take me into your bathroom with your cell phone, or, you know, bring them all out to our visit so we can look at them and really think about that. So it's just an interesting, different opportunity. And if that's not something that folks are doing, certainly, you know, I keep hearing that as an anecdote of kind of one of the silver linings of the way that we're doing business right now. But you know, as you were alluding to, really providing, especially folks living with mental illness and many challenges, having somebody who can help them advocate for themselves, and help, you know, really to form a bond that maybe, you know, individuals sometimes don't have, makes me think about it. Maybe, you know, I anticipate there's probably some sleep improvements from this research, but there's a study that was done here in Massachusetts, sort of this hospital to housing model, really looking at people who are experiencing homelessness, and for the most part, we're looking at folks who are also experiencing mental illness, and providing a very intensive permanent supportive housing model where they're working with a case manager who's providing very intensive support to help find them housing. And that initial research showed that even before people found housing, there was a decrease in emergency department utilization. And as we're starting to try to, you know, replicate that program, that was not, you know, not one that my organization did, but as we're trying to replicate that with our flexible services work, you know, seeing the ways in which some of these advocates who aren't community health workers, you know, they're stationed in a nonprofit organization as opposed to the health center, but are really able to connect with individuals in a different way, and they're getting phone calls back. You know, they become the person for some individuals who maybe don't have that right now. And so I think the more we can think about, you know, those individuals who can play a navigation advocacy role for individuals, we'll see all kinds of benefits. Like, I call this person every Friday before I go home from work, and that helps him to talk through the issues, and that keeps him out of the emergency room on Saturday or Sunday. And I anticipate there are a lot of other really good consequences that come from that, including things like, you know, understanding medications and when to take them, and improve sleep, and some of those things as well.
And Andrew and Kim, just as you two were talking, I think the word that came to mind for me was just agency, and sort of instilling and working with to promote a sense of agency, particularly, you know, in instances of extreme poverty or multi-comorbidity. So just sort of, I just wanted to name that, because I think that's part of a related piece that you both alluded to.
Yeah, and there's yeah, the polyprescribing. So I'm just kind of looking through the chat as we talk here. You know, there's another thing that and I think we'll just have like one or two more questions, and then we'll wrap up for today. But you know, it's interesting, even looking at my sort of like set of faces here on the screen. You know, I think about kind of the different backgrounds that we're coming from, like professionally, particularly. You know, more and more, and we just did a panel a few months back where there was this kind of call to action around forming partnerships for research, for telling a story with data. And I think that's something that particularly those of us who kind of work primarily in clinical settings, we always think of ourselves as researchers and sort of experts in analytics always, but we do have at our fingertips these incredible, especially now, as much of a headache as they can be, our electronic medical records and things like that, this incredibly powerful engine, but a lot of us don't necessarily have the wherewithal to sort of turn that into something usable from a data perspective. Particularly from like a researcher perspective, like any suggestions in terms of how we can use the data that we may have at our fingertips, or even form partnerships with folks in research positions to look at the data that we have to see where might disparities exist, to really point our interventions. You know, is there something when we look at the limited resource that we have at our disposal where we really need to target them, or where we need more targeted intervention to resolve some of these gaps? Any tips for folks who aren't necessarily pros at doing this, but may have access? Can I reach out and work with you?
I'll just jump in. I mean, I think there is a lot of data out there to be mined, and you know, I think, you know, partnering with people who have those interests, and I think, you know, probably many of us have access to data where we can maybe start to replicate some of these disparity patterns. And I think our challenge is to see, you know, what else is in the data that can help explain the disparities, right? And so to the extent that we move beyond just describing what the disparities are, but starting to look at what are some of the, like all the things that we've talked about, contextual, family, work life, all of these, you know, material needs, and start to unpack some of those as maybe drivers of or explanations for the disparities that we see, that then we'll start to really begin to mitigate the disparities. So I agree, there's lots of untapped resources and data out there that we can use better to begin to address sleep disparities.
Yeah, I think that's, you know, that would be sort of like one of our, you know, kind of hopes, I think, here is that, you know, folks who do have access to information continue to use it. And, you know, as we move towards more, you know, using data dashboards and risk stratifying populate, you know, as the move towards value-based care, like this is becoming more and more common. But to Tiffany, your point, I think we're often using this to sort of like see like, well, just sort of like what's at the surface level, how can we sort of separate people, but not necessarily looking at drivers. And again, you know, one message that we're going to keep sharing throughout this series is looking at our impact and our sort of whether we're sort of implicated in some of these discrepancies and disparities, or certainly not necessarily moving the needle on them. And so, you know, even when I look at diagnoses, when we look at insomnia, for example, knowing with the information that you've all shared with us today, where we know that you know, individuals are disproportionately impacted by poor sleep, or feel the impacts of discrimination, then that directly impacts sleep quality. If I know that, you know, from conversations like this, when I go back and I look at the diagnoses or the, you know, what's showing up in the medical records at a population level, I imagine that if it's not reflecting that, you know, those are some things where I should sort of at least view those as a flag of like, what's going on here? If I sort of know that there's it's sort of a population level, we tend to see these disparities, but I'm not, that could be great. Maybe, you know, my folks are immune to it, but maybe I'm also, it's a sign I'm not asking the right questions, or I'm not setting up a space where people are getting access to care, or, you know, something like that too. So I think kind of looking at where there isn't data, you know, where there aren't certain things where, you know, we just kind of know it, like you said, from existing research that's been, you know, put out elsewhere, that we should be seeing something. If we don't, and it wasn't because of some amazing intervention we did or the community has been doing, you know, are we kind of missing something there? And then through inaction contributing. So I'm gonna wrap us up. Any final words for in this discussion or for the audience, our esteemed panelists here?
I think I'll just say, I didn't say it before, but a lot of what we talked about really makes a case of thinking about sleep as a social justice issue. And so I think just as we think about sleep, I think being able to intentionally use that language and tie it to that kind of framework is really important and powerful. So just want to, I think, remind our audience that sleep is a social justice issue for all the reasons that we talked about here.
Well said, absolutely. Thank you all.
Couldn't agree more. Well said.
I think that's what we'll go out on here. So thank you, everyone. We've got your contact information in the slides, and I'm not sure if you're able to bring up our kind of final slide here. Again, we will make today's discussion available through, or you've got my contact information. We'll have your contact information there on the website available if you don't mind. Actually, no, I know it's in the, if we go back to sort of our initial slide, we have everyone's there. There we go. So, again, thank you, panelists, for joining us. Your backgrounds are humbling and incredible, and also just getting to hear and have this conversation is an honor. And certainly our audience has echoed this as well. We appreciate this. Our goal is that we wanted to sort of to highlight and give voice to a discussion around disparities, but this will also continue to be part of our discussions in every part of this series. So we invite everyone, including our panelists here, to join us next month, where we'll be talking about specific behavioral assessment and intervention for sleep. And shortly after that, in March, we'll be talking about, we're hearing from patients and families themselves and their experiences with sleep concerns. So thank you, everyone. Thank you again, panelists, for this call to action. And thanks to our audience for joining us and participating and contributing to this conversation. To SAMHSA, our Center of Excellence for Integrated Health Solutions. We will keep this work moving forward today and tomorrow and into the future. So thank you very much.
Thank you.
Thank you.
Thank you.
Thank you so much.